Front row. Okay.
Ariana, will you just let me know when everyone's been admitted and I can get started?
Yes, everyone is in now.
Great. All right. So without further ado, everyone, we'll get started. Welcome to our fourth and final for this year webinar in our Equitable Care series. My name is Dr. Kathleen Kieran, and with Dr. Peter Asante, I'm the co-chair of the Equity Work Group for the Washington chapter of the AAP, and I wanted to welcome all of you to our fourth webinar. This is Undoing Institutional Racism in Healthcare, and as you can see, we have an amazing panel for you today. Move on to the next slide. So we're going to talk a little bit today, just any meeting should have an agenda, and I apologize for getting started a couple of minutes late. We had some technical issues, so I want to just jump right in so we have enough time for this panel discussion. I'm going to give you a little bit of background for those of you who are not familiar with our Equitable Care Work Group and Toolkit. We're going to talk a little bit about promoting equity, diversity, and inclusion in healthcare organizations, and then undoing institutional racism in healthcare. And as you can see, we have our three panelists today, Dr. Kristen Kahn, Martine Pierre-Louis, and Dr. Maricela Sanchez. And this is going to be an amazing talk. So I want to cut my part short and get to them. Next slide, please. All right, so in terms of the background, the Equitable Care Work Group came about 18 months ago and had been something that had been considered for a while, but certainly with the events in the spring of 2020 and the national reckoning with regard to, in particular, racial disparities and racism in this country, we felt that as a group it was time to establish and really work forward very formally to promote a toolkit. And this toolkit was the deliverable from this work group and one of the many things that the work group was doing. But this toolkit was established with the goal of supporting clinics, healthcare providers, and everyone who cares for children and their families in terms of providing equitable care, making healthcare more welcoming and responsive to families and children of color, and delivering high quality care to the diverse patients and families in Washington state. And it's available on the YCAP website. I don't know if we were able to put that link in the chat for those of you who may not have seen it, but you can look at that. We are responsive to feedback and we update it periodically. Right. In terms of promoting EDI and healthcare organizations, I know this is very small print here, but this is an area where you can take and look at what your practice is doing and help your practice to do the 3 A's: assess, take action, and amplify efforts within your institution. So what can you do at the ground level, at the institutional level, to help promote equity within your practice? And it's a summary of best practices from Washington state institutions. And certainly, of course, there are remaining challenges there. So again, we are open to feedback and information there as well. And you can take a look at that, and it's also on the website. All right, I'm going to turn it over to Dr. Asante for the introduction of our amazing panelists. Thank you again for being here this morning.
Good morning, everyone. I'm Dr. Peter Asante. Welcome from Yakima. It's still pretty dark outside. So thank you all for joining us this morning. I am here to introduce and moderate our panel this morning, and I will give introductions for our panelists first before we get started. The first person is Dr. Kristen Kahn. She's a family medicine physician and medical director of Equity, Inclusion, and Diversity for the Washington Permanente Medical Group. In this role, Dr. Kahn is the lead medical executive for promoting cultural intelligence and fostering an inclusive environment for more than 700,000 patients and 10,000 employees and clinicians of Kaiser Permanente, Washington. She partners with leaders and clinicians throughout the organization to integrate equity into all aspects of operations, patient care and access, clinician recruiting, community engagement, innovations in telehealth, and more. Dr. Khan also works closely with an advisory board of clinicians to address numerous impacts of systemic oppression, bias, and stigma on the health and well-being of patients and employees. Prior to her residing in the Seattle area, she built a prenatal practice and led family planning and women's health for a community health center serving patients in East and South Central LA. In the community, Dr. Khan currently serves as a primary care physician representative on King County's Accountable Community of Health Governing Board and is a clinical assistant professor in the Department of Family Medicine at the University of Washington School of Medicine. Our second panelist is Martine Pierre-Louis. She has worked to improve healthcare access for refugee, immigrant, and deaf communities for 3 decades. She has worked at Harborview Medical Center for nearly the last 20 years and currently serves as Director of Equity, Diversity, and Inclusion for the hospital. As a founding member and past board member for both the Society of Medical Interpreters and the National Council on Interpreting and Healthcare, she collaborated on multiple community-based public health efforts focusing on access, healthcare quality, and wellness outcomes for those same communities. Her work within institutions has centered on partnering with quality improvement departments to track and measure disparities by demographic metrics such as race, ethnicity, and language, and collaborating with healthcare teams and community partners to develop innovative programs to decrease their impact on marginalized populations. And our third panelist is Dr. Maricela Sanchez. She was born to a Mexican immigrant family in the Yakima Valley. Growing up, she worked together with her family as migrant farm laborers, picking crops throughout Washington state. After receiving her bachelor's degree in American Ethnic Studies at the University of Washington, she worked as a middle school math and science teacher in Los Angeles with Teach for America. Dr. Sanchez went on to receive her degree in medicine from Stanford University and completed residency and fellowship in anesthesiology at Columbia University. She is a practicing anesthesiologist at Cadillac Regional Medical Center in Richland, Washington. And those are amazing panelists. Before we get started with the panel discussion, I just wanted people to know that as we are talking, people can send comments and questions in the chat, and then we will summarize and address them after we've completed our panel. So thank you guys so much for doing that. Certainly, if there's any comments or questions that you would like to submit just to Kathleen or me, that is also okay. So feel free to do that, and we will share that anonymously as well. All right, let's get started with our incredible panel. So we will start with our first question, which is for all 3 panelists. And I also told all 3 panelists that sometimes I will cut them off, and it's only because I want to make sure that we get through all the questions and get to the Q&A at the end, which is going to be very exciting. So for everybody, can you share one success and or one challenge in the work that either you or you along with your institution have experienced in the field of advancing health equity in the last 12 to 18 months? And we will start with Dr. Kristen Khan.
Thank you, Peter. And hey, good morning, everyone. It's great to be with you on this Wednesday morning. And I just want to thank you for the invitation and also acknowledge the incredible work of your own toolkit and the webinar series over the past several months. I mean, it's just tremendous. I think for many of us, the pandemic was really a crash course in how structural factors contribute to health inequities, and that those structural factors have very, very real consequences in the lives of our patients and communities. And health systems were really not designed with this in mind. And since the pandemic isn't over, it is something we continue to reckon with. But thankfully, it's also provided a platform for us to have conversations across the organization about systemic oppression. And so for us, what that meant, I'll tell you about a success and a challenge. What that meant was recognizing the need for our internal transformation. And that includes everything from disaggregating all of our metrics, quality, experience, by race, ethnicity, sensory impairment, and other factors. It also meant really paying more attention to screening for social determinants of health, and also creating more community collaborations. And on the last point, our Washington Permanente Medical Group Board of Directors is really thoughtfully exploring how to do this with community-based organizations in a way that is collaborative and not transactional. And then the last thing I'll add is recognizing that we just don't have the structure in place to overcome systemic oppression. There were sort of three pivotal moments. One was our Board of Governors creating an anti-racism strategy, which is a roadmap for the future. The other is creating 2 new positions within our organization that are really deeply focused on the work. One is healthcare professional pathways program, that ecosystem of growing our own, more students from underrepresented groups pursuing health professions. And I'll be happy to tell you a little bit more about that later if people are interested. And then the other is a new position within our Thriving Families program. And Thriving Families is the combination of midwifery, obstetrics, gynecology, and pediatrics. And clearly, all of us know that medical institutions really need to take ownership of the fact that we have terrible inequities in that perinatal sphere. So we now have a position that's going to really have a point of accountability for that work within our group. So those were some of the successes, but continued challenges.
Thank you. Martine, you're next.
Thank you. Good morning, everyone. I am really honored to be joining this conversation. For us, I can share one success, and one of the things for us is, really believe in celebrating, kind of the small and the bigger successes. One of the things that we really see is in terms of language and understanding, we don't have the same understanding of terms like equity, diversity, and inclusion to even be able to start conversations around this. And so, I don't know if this fits in, where this fits in terms of large or small accomplishment. But one of the things that we pushed really, really hard for as an Equity Council was to have implemented within the annual education that all staff have to take an equity, diversity, and inclusion module that had definitions so that we could come to at least some same language around what we mean by racism and disparities and such, and hopefully be able to share some same conversations. And in 2021, we have had over 4,000 staff at Harborview be able to complete that required education. And so that for us was one really tangible accomplishment. And we're going to improve this because, part of the really important feedback that we received was that even though folks did complete this education, and we're talking about staff ranging from our front desk staff to administrators, people working in environmental services. I mean, really all of our staff. The reading level for this was actually college level. So we did not get it right. So we need to revise this education to make sure that we get the reading level right. So the learning continues. We're going to tweak it and make sure that we get the reading level right, and present modules that are robust, but then continue to expand the conversation. Thank you.
Thank you so much. Dr. Sanchez.
Hello, good morning, all. I would say being located in Eastern Washington, which has a very particular history and has a very particular economic and racial environment, I would say one of the biggest successes in the last decade has been the establishment, relatively recent establishment of medical training programs here. So a new MD and DO school located in Eastern Washington, as well as the expansion of nursing education programs so that we're able to draw students who are from the area to become practitioners here in the area that understand the community. One of the challenges that we continue to face at our institution and other institutions in the region is the shying away of looking at our medical practices through a racial lens or a class lens. I think there's still a tendency and an insistence on approaching any issues within our institutions through a race blind sort of approach. And that can prevent us in really seeing and acknowledging some of the disparities that exist.
Yeah, that is a perfect segue, Dr. Sanchez, to my question for Dr. Khan, which is how can we work to create consistent alignment of expectations within our institutions so that we can effectively develop and support equitable care for our community? And specifically, what is the first and what is the second step to that process?
Thank you, Peter. Such an important question. And I just want to acknowledge that I'm going to bring a perspective that's really unique to our organization and being Kaiser Permanente, because Kaiser Permanente sort of has a long history of being intentional about equity. In fact, this year we celebrated our 43rd, I believe, National Equity, Inclusion, and Diversity Conference. So for 43 years, we've been convening this conference across the country, all the Kaiser Permanente regions. And our previous and unfortunately late chairman, Bernard Tyson, who ran the organization, was really a bold and unapologetic advocate for health equity. And his personal story was one of someone who had worked his way up from an entry-level job to become chairman. So in many ways, he was the very embodiment of what it meant to have an inclusive organization. Unfortunately, he passed far too soon, but he's really cemented his legacy in many ways, one of which is that there's the KP School of Medicine, which opened last year and is named after him. But the reason I bring this up is because in 2021, one of our enterprise-wide goals, so this is for all 8 regions of Kaiser Permanente, from Hawaii to Washington, D.C., including Washington, one of our enterprise-wide goals is delivering equitable care. And it's defined in a very precise way. But what it does is it makes it clear to everyone, regardless of role, that this is the direction we're going. And it means all of us, not just the EID team, is responsible. In addition to stating it, again, there are defined metrics. So we know what success looks like. We know what the targets are. And we build in the accountable ownership along the way. But I'll take us back a little bit, because 5 years ago, when we were Group Health becoming Kaiser Permanente, we really were starting from scratch and did not have much of a basis to build the equity, inclusion, diversity work on, although we had a very strong population health team. And so what we did was what all the clinicians on this call do every day. We went through sort of a diagnostic process. And this is that A in your toolkit around assess. You literally can't skip this step. You have to spend a lot of time. And this is about truth telling, right? This is about do you know that your organization, like ours, has DNA in it or has equity in its DNA or not? And if it doesn't, why not? Listen to the stories that executives tell, because there might be real hints that equity is foundational or that it's not. We have to do that sort of 360 assessment, ask our members, ask our community, and then look at the metrics. Do you disaggregate your data by race and ethnicity and sensory impairment and SOGI? Do you do that? And if you do, what does that data tell you about your attention and your ability to provide equitable care? So I think that diagnostic piece, what you call assess, is critically important. And then once you determine where you are, that has to be shared transparently. And that's the process that we went through as well. The beautiful part about that is the allies and champions will come out of the woodwork to become part of your guiding coalition. And that's the next step, the guiding coalition. And it's with that coalition that you can really develop a vision. And you have to go back to the truth-telling piece. Is your organization in the denial phase? Because if you are, then your early steps are very basic. They're steps like defining what racism and equity and inequities are. And then if you're further along in this continuum of equity, then your work looks a little bit different. And then I'll add, and this is the last point, well, there's lots of other points, but I know I have to wrap it up, that you can't, as an organization, I don't think you can be successful and move forward if your most senior person is not completely on board with this work. So it makes sense to spend some time with your board of directors, with your president, to really get their approval, their participation. I have to tell you, it makes my heart feel so good every time I hear our president say it's an imperative that we reduce variation in care across groups that we care for. That's his way of saying, this is a priority. Inequities are not something we're going to tolerate. So spend time in that step. And then just as importantly, with those allies and co-conspirators and champions, that's where you develop sort of the grassroots, the community organizing approach to bring everyone into the work. So there's lots more to say, but I would say that is where we started. And I think that's set us up for success.
Thank you so much. Actually, Dr. Sanchez, I'm going to go to you next just to piggyback off of what Dr. Khan said. So in your area of Eastern Washington, how does the institutional community will, that's what I'm calling it, impact how you or your colleagues might approach tackling issues related to racial health equity? How can providers and or trainees best hold their institutions accountable for meaningful change when it comes to addressing these inequities?
I think in our community specifically, there is, the entire topic is a very touchy and emotionally charged topic. I think that there is a belief community-wide that we do all care for each other and that nobody as neighbors, but it's not encouraged to be viewed through any kind of a racial or ethnic lens. And so it was heartening to hear Dr. Khan say that if you're at the beginning of this, then your steps are rather simple. So being able to assess and present data, I think, and sort of initiate that conversation as, calling people in that if you do care about your community and if we are serious about ensuring that all of us have access to excellent care, then it's imperative that we make steps forward to be honest about what we're seeing and to be honest about that within our community and to not shy away from telling the truth.
Martine, this is now we're taking it to the clinic. So how do we members of institutions deal with the tension acts of racial health injustice and with the tension that acts of racial health injustice can and will occur within our own professional spaces, and move the conversation forward in a manner that positively impacts the patients we serve?
Well, I connect so well with Dr. Sanchez's comments and Dr. Khan's comments about really knowing very well the culture of the communities within which these institutions function, and knowing the culture of the institutions themselves. You know, I work within an institution where you know, that is incredibly reactive in culture. And so, for example, we do have a strategic plan that embraces equity. And yet, when we do see stories and incidents that happen locally or nationally that really lay bare issues of you know, basically racial issues or issues of bias. I know one of the questions that I get a lot from leaders here is, you know, could this happen here? And you know, I have gotten accustomed to actually turning this question around because, you know, initially, folks were looking for reassurance, as in, no, this couldn't happen here, that our systems are better than this. And I am not here to provide reassurance. I'm here to speak truth about our systems that are patently racist. You know, we do work within systems that are racist. This is the reality of systems that actually continue to turn out the data that we see nationally and also within our own institution, where people of color and folks that are limited English proficient really do fare less well. So we have to be able to connect the data that we see with the realities here. So I turn kind of that question of, could this happen here, on its head? And I say, well, my sense is, yes, this could happen here. Can we actually reframe the question to, how could this happen here? And can we look at the mechanisms by which this could happen at Harborview? Can we ask that question rather honestly? So for example, last year, when a physician, an African-American physician, posted on Facebook how she received less care, how she was denied pain. My question was, so have we looked at our own ways that we prescribe pain? And if our own strategic plan is not looking at this, do we have gaps? So these particular incidents that arise, you know, again, nationally or locally, give us an opportunity to look at our own plans and identify some possible gaps. And, we have had to tweak, we have had questions rise that have helped us to identify some gaps. And sometimes it's not necessarily gaps that we can take care of right away. Some things that we have to delay, but let's ask the questions honestly, and let's not ask them to actually make ourselves feel better. Let's recognize that, yes, we are working with biased institutions. And so, this is the conversations. These are the conversations that we have within our institution. And those are the ones that we're going to have for many years to come.
Yeah. We have 12 minutes left and we have 3 more questions at least. So I'm informing our panelists you have 4 minutes for each answer. But Martine, actually your comment struck up another question for me that we've talked about before, which is, HR policies at health institutions have been a big factor in limiting diversity of healthcare worker staff, and especially in limiting staff who self-identify as Black, Indigenous people of color. Are there any changes in your institutional policies that have improved that level of diversity within the institution?
I have to say that we're having conversations now with members of BIPOC communities and community health boards that I believe will lead down the line to some changes within our human resources. And these are incredibly difficult. And those are changes that we have to undertake. I will leave it at that. But those are incredibly necessary. We have had incredibly important conversations with community health boards about what they consider qualifications that are significantly different from what our human resources consider qualifications.
Yeah. Oh, that's really great. Dr. Khan was talking more about implementation. So what are ways in which individual providers and or trainees can start to implement concepts of racial health justice in their clinical encounters? How do we go from these individual acts to scaled up operationalized workflows?
Well, there's lots to say here. And before I get to that, I want to just, Martine, thank you for your words. It reminds me that who you hire really makes a difference. And one of the ways in which we're trying to ensure that the folks coming into our organization are aligned with our values is we ask them in interviews now about their understanding of health equity, what the biggest obstacles are, and how they think they can contribute to our organizational mission. I think when you have a group of folks who are coming in with that intention, you're starting from a different place. And we also ask that in all our leadership interviews as well. But in terms of the individual clinician, the work really starts with that self-awareness and humility. That's a big part of it, as well as curiosity. Being a good person who cares about others, which I assume all of us are, is just not enough. Because we have brains, we also have bias. And I know none of us wants to be that well-meaning person who causes harm. Although many of us have been that person, I have. So it's really important for us to have that humility, for us to do that self-assessment, identify our biases. The IAT, the implicit association test, is a good resource, and you've got great resources in your toolkit. And, honestly, I certainly don't feel like I've arrived. There's always work to do. And I think many of us really can benefit from doing this work in community and conversation with others. And if you have a team that you feel especially safe within that team space, that's a great place to have those conversations. I think ultimately the goal for us as providers is to create psychologically safe spaces for the people we care for and for their families. And so that really involves building trust. There's this trust triangle that Francis Frey has talked about in their TED Talks. And it's mostly for leadership, but I find it really helpful when I think about interactions with patients too. You know, one corner of that triangle is about logic, another is about being authentic, and then the third is empathy. And I think those are really the core traits that are needed in order to create trust in any setting. And if you wobble at any one of those three, people can see right through it, and that creates a sense of it not necessarily being safe. So I would just recommend connecting with a cadre of folks who are really interested in this journey, have those conversations. The last thing you asked about scaling this up. So we have a few on this call, pediatricians who have been just brilliant co-conspirators in our work across the organization. And we have another pediatrician who's been piloting an effort to ask our patients very directly about their experiences with racism and their perception of how it's affected their health and well-being. So those questions are being piloted. We have a few more folks who are going to join, a few more providers who are going to join in that pilot. But so far, we have learned quite a lot. One, that, you know, some people opt out and they don't feel like that's something they want to talk about. But for those who do, there's this real connection that happens with the provider, and the provider learns quite a bit. So it's a really interesting and I think important conversation, and totally in line with the AAP's statement about racism, you know, as a form of harm for health and well-being. So we haven't talked about algorithms and bias or patient education or the physical space. There's so much to talk about, but in terms of sort of direct clinical activity, I think this is a good starting point.
Absolutely. And Maricela, Dr. Sanchez, just to get even more granular, simple question with a difficult answer, I'm sure, but how can we start to advocate for greater racial health equity in the age of telehealth and telemedicine? Good luck.
I mean, this is, I think one of the things that we can start to do is just by acknowledging that there is that telemedicine and telehealth is going to be a tool, but it is not going to be a solution for access to care for communities. We must acknowledge that there will be segments of our community that absolutely must have an in-person interaction, and that we need to ensure that there's a variety of ways that we can access health, and that we are not sort of trying to use one blunt solution as a way to say, you know, this is the thing that will level the playing field and overcome issues of, you know, transportation and access. And so I think keeping that in mind and knowing that we need to continue to ensure that there are multiple modes for people to be able to access healthcare and healthcare providers. I think that we still, there's still quite a lot of room left to improve that particular tool, knowing that it doesn't apply to all patients and will not apply to all patients for, you know, across generations and across language ability. And yet there is still, you know, there is still improvements that can be made, particularly in rural communities, in terms of access to internet, access to technology. I think that there is a greater need for folks that are involved in healthcare to expand a bit beyond their institutions and to look for ways in their lives in which they can be involved within their municipality and county governments, and really trying to see if there are ways that folks can reach out into other sectors, because there are so many factors outside of the walls of our institution, whether that's our transit systems, our the methods in which housing is built, that all have such a profound effect on whether people can access the services that they need. So I would encourage anybody who is listening in and here on the call, if there is an opportunity to become involved outside of the medical sphere, in areas that also have an enormous influence on public care and access, that we really search to fill those roles and to help to contribute to decision-making with those services.
And I will just put Dr. Sanchez on blast because she is an excellent epitome of this work that she is talking about in terms of reaching across sectors. She's done some work in the community around like public office, as well as urban planning. So I really, really appreciate you talking about the interprofessionalism that we should all participate in to impact the care and well-being of our community. So thank you so much for that advocacy across the board. We are, I love it when we're on time. So that was perfect. That was incredible. We have 15 minutes left. I do have a couple additional questions, but I wanted to turn the rest of the group loose in the gallery. Certainly, if people have any questions, they can unmute themselves and ask those questions of our incredible panelists this morning. And before, actually, I'll let Kathleen, if there were any comments that came through, or any questions that came through, let us know before I let other people start asking questions.
There were not any questions that came through the chat. I do have a question, but I will open it to the floor to see if anybody else has a question before I ask mine.
All right. Any questions? All right, I'll let you go. I'll let you go first, Dr. Kieran. Go.
Okay, great. Because this, Dr. Sanchez, this kind of piggybacks. I just texted you because I said, "Oh my goodness, I had a question for you, and you're starting to answer it already." But we have talked a lot today about vertical accountability within organizations. We've touched a little bit on horizontal accountability, but I loved where you were going, and I know you. So I know how much work you're doing in the community. And so I really just want to say that Peter's shout out was just the tip of the iceberg of what Dr. Sanchez has been doing. But the question I have for you specifically is that one of the challenges with being a healthcare provider is that I don't think that we have as much horizontal accountability to our communities as we could. And there's a lot of emphasis right now on telehealth or outreach clinics and bringing things from larger cities and larger medical centers to communities. And ostensibly, this seems marvelous to be able to provide services in the community. But we know that sometimes that can lack accountability, or the perception of accountability, or the perception of lack of integration for an appreciation of the community. So I was wondering if you can speak a little bit to how having different providers from physically different places plays into health equity in the institution. And also, if you would be able to talk a little bit more about some of the physical constructs, like you talked about housing developments, for example, and cul-de-sacs, and how cul-de-sacs are basically designed to make you need a car and not be able to walk, which means you get different food, you have different access to places, you may have more obesity, that kind of thing. So can you talk about sort of that relationship between, we're from the big medical center and we're trying to make things better in the community, and are we missing the mark with that a little bit?
So a lot of facets to that question, Dr. Karen, but thank you. I think one of the the first thing that I thought about when you asked about, how can we ensure that we have sort of a broad reach and we're really bringing a wide variety of folks in. I'm thinking back to Dr. Khan's comment about providing a psychologically safe space for patients. I see that in the sort of rare instances when we have a patient come and we have a provider that is, shares their language or is from a similar background, or that they can have some sort of a kind of a personal reflection of self and an acknowledgement of like, this person is from my community. Just that sense of relief, it's palpable. And the sort of the curtain that sort of falls in terms of, oh, this is somebody that I'll be able to be frank with and that will receive my responses. I just see a level of comfort that is visible, and I can feel it. And I would want for people to have that as often as possible. I think one of, in terms of CADLEC, one of the things that can be done quite easily at this point is ensuring that we're drawing from educational institutions that are really placing a focus on bringing students directly from the community. So at this point, we have an example that I'm thinking of is we have 3 nursing programs within the Tri-Cities area. One of those is from a majority minority university, Heritage University, which has a student population that's 70% Latino and 11% Indigenous. That is the only institution that is not currently working with CADLEC Hospital, which is the largest medical center in our region. It would just seem like such an easy fix and such an easy, simple step to ensure that that nursing program is involved with our institution, because we serve the most patients here in this region. To the other point in terms of, kind of larger issues surrounding housing, transportation, and how that all plays in with public health. I think we can't divorce or separate the idea that the way that our environment is built has such a direct impact on public health. With the amount of trauma, vehicle collisions, pedestrians being hit on our city streets, the inaccessibility of homes to shops and grocery stores, all of those things have such a direct impact on our issues of chronic health. And so I think sometimes we see them as neutral and, see the status quo as sort of, well, this is something that everybody, everybody deals with. Everybody has to hop on the freeway to get to that grocery store, and that's just the way that it is. But if you have a segment of the community that may not have access to a private vehicle, may not have a backup plan when that vehicle breaks down, then what becomes perhaps an inconvenience or an annoyance to one community is actually, severely impacts the life of a community that has less access and fewer means.
David Willis, you are next.
Great, thanks, Peter. Thanks, Kathleen, for this amazing webinar, and to our panelists. It's truly inspiring to be thinking with you together. Kristen Khan, I want to ask a specific question related to the family or the patient survey that you referenced about the patient's experience of racist structure in care. And I think a lot in primary care pediatrics, I think about the relationship between the physician and the family, and how lived experience and the information brought forward to the pediatrician could be so valuable at the individual practitioner relationship experience. And I wonder if you could comment more on that tool and how you've been using it within primary care practices, and what are the most startling or most important first level discoveries, and what it means to the clinician themselves when they gather this individual experience of their own encounter that they've created with their families.
Thank you for that question. And I will say there isn't a tool yet. So let me tell you a little bit about this, because I think this will get to Dr. Hoops's question in the chat as well. Her question was about research-free areas. When the pediatrician, Dr. Block, who started exploring this question, looked at the literature, there really are no validated tools around discussing racism with families or children or even adults in medical practice. So we created our own couple of questions. And so that's sort of the phase we're in right now. So I'll tell you practically how it's working and what we're learning. The medical assistant sort of prepares the patient and says, the doctor has some questions around your experience of racism, and think about whether or not you'd like to have that conversation. So that way, by the time the provider brings up the topic, the person has already had a chance to think about whether or not it's something they want to talk about, and they're able to say, no, thank you. And what we have found is that of the folks who identify as Black, Indigenous, people of color, the vast majority want to have that conversation. They opt in. And because there was such a high opt-in rate, we actually expanded, or Dr. Block quickly expanded from just asking families of children to asking any adult who was there for care. So, and some of the insights were a lot of adults worry about their children, even their adult children. A lot of middle-aged adults worry about their older parents and their experiences with racism. I will say, especially among Asian Americans this year, there was, quite a few people express concerns about their older parents. And what I think Dr. Block was surprised to learn was that people were not so interested in solutions. They were not looking for a referral. They were not looking for, a solution. They really just wanted to have the conversation. Now, there were some folks, I think in her preliminary sort of analysis, there were some younger adults who were interested in either online or virtual experiences of sort of unpacking racism and systemic oppression. But I think no one really wanted a referral to a therapist. Nobody wanted, none of those things, which was part of her premise going in, that what we would do is unearth, real hurt and harm from racism, and that it would be a referral to a therapist. And that clearly was not what she discovered. So we're in the process of expanding to 4 or 5 other providers, and we'll continue to sort of hone what the best questions are. She started out with 4, and I think has identified that there are probably 2 that are the most effective at launching the conversation. I hope that's helpful. And in the end, we hope to have a validated tool that we can share.
Wonderful. And just cognizant of the time, and I know we have a couple of other questions in the chat, but and this is obviously an amazing topic and so much to discuss, but I do want to turn it over to the other 2 speakers as well, because Dr. Khan, you started to answer Dr. Hoops's question in the chat. And so I think this is actually a great way to end at least this 60-minute session in this discussion, to think about the next steps. Martine and Maricela, what do you think are the most pressing research questions in this arena?
Dr. Sanchez, why don't you go first?
I think I need a little bit of time to think about this question, but I'm wondering if there are. I worry about a bit about the outcomes that we or the outcomes or issues that we don't know about, and how, we can measure certainly what happens within within the walls of our clinics, within the walls of our hospital, but sometimes I worry about how do we measure those patients or families that are falling between the cracks that we never see. And is there any way that we can assess that from an institutional level, or is this something that requires partnership with other sectors like social work or public education to really be able to identify those things that we aren't seeing?
Martine, you have the last word.
So I guess very quickly, I was listening to the outgoing director of the NIH yesterday speaking about kind of what he felt his great successes were. And, raising the budget of the organization. I think what I wish I had heard was greater listening and partnership with community groups. And I think, I don't know that that is the greatest thing that needs to happen. But that is one of those things that I feel is really, really missing. There is wisdom and there is connection, and there are broken relationships that really need to be mended. And the more time that I spend in community, the more I really believe that wellness and well-being actually happen in community, and just a small amount of health actually takes place within our institutions, and that we really need to keep that in balance. And so we need to repair those relationships to actually allow for information that we, I shouldn't speak as a clinician, that clinicians have to share is listened to and acted upon. So.
Thank you so much. That is an incredible answer, especially because you had to defer and then you created this wonderful way of sort of summarizing the work that we've been doing in the Equitable Care Work Group. I think that the word of the year is really intersectionality, and that's not with respect to our identities in terms of who we are as people and how we identify and move in the world, but also how we identify professionally and reach out into the communities that we serve to make sure that the work that we're doing is integrating for the lives of our children and families. That, just like you said, most health and well-being is not in the clinic, it is in the community. And so if we sit in the ivory tower waiting for everybody else to show up, then we really aren't doing the work in an equitable way. So I really appreciate all of you for really highlighting that. And I think, to speak to Dr. Hoop's question, that is really the evidence-free zone, is how do we create greater range and coverage in the work that we're doing, whether that's in schools, whether that's at the Boys and Girls Club or the YMCA, whether that's at a community health board. How do we bring people together so that we uplift our community? So thank you so much for really shining a light on that. And I just want to thank our three panelists. And I will give Kathleen the last word. But again, thank you guys all so much for coming this morning.
Great. And I just want to echo those thanks. This was an amazing panel discussion. It always seems like we don't have enough time and we've just scratched the surface, but thank you for giving us so much to think about. We really appreciate your being here this morning, all of you, and for the rich discussion. Thank you so much. Have a wonderful day, everyone. Bye.
Thank you. Goodbye.